Good afternoon, dear colleagues and friends. I am Pepe Zamorano, the head of cardiology of the University Hospital Ramón y Cajal in Madrid, and really welcome to this virtual session related to residual cardiovascular risk. What is the role of icosapent-ethyl? We have great professors today. We have great speakers. Even better, we have great teachers. And I'm sure you will enjoy this afternoon. First, we will have Professor Alberto Zambon from Padova in Italy, and he will speak about residual cardiovascular risk, what is really this, what is the role of lipids and inflammation, and how to identify the patient. Then, Professor John Chapman from Paris, France, he will speak about icosapent-ethyl. I think, what do we know? And this is extremely new for us, and it's a great session to present what is really new. And finally, Xavier Garcia-Moll, very well known here in Spain, from Santa Creu in São Paulo in Barcelona, he will speak about the evidence and the guidelines recommendation. We have terrific teachers, but the important thing and the real important ones are you all. So this is the second session of the cardiovascular virtual topic. You are welcome to participate in the discussion. And don't forget to send all your questions. And the teachers, the speakers will clearly answer with easy answers for complex questions. You can share your thoughts on Twitter and follow the summit with hashtag residual risk or hashtag CBBT 2022. Thank you to the Spanish Society of Cardiology and Amarin to sponsor. And without any delay, we will start with the first just introduction that I will simply address the topic about what is the residual cardiovascular risk and if we can do more. Well, I think that it's extremely important to know and to identify residual risk. And what do we mean by residual risk? Is the risk that persists in patients after applying our standard care. So the problem is that we have great treatments, great drugs, but still we have residual risk with implementing all the therapies that we do have. So no doubt that despite the cardiovascular benefit of lowering the LDL with the different therapies, still we have significant residual risk that remains, and we need to do something about. Even if we look to the latest trial, so we know that with PCSK9 inhibitors, we reduce dramatically LDL, but still you can see here that we do have still residual risk in those patients, even if we reduce dramatically the LDL. And in fact, residual cardiovascular risk, despite the LDL control, is an important part of the picture of our patients. So what can we do? No doubt that the best thing to do is to pay attention to our excellent speakers that you will see after my presentation. But we have residual cholesterol risk with an LDL above 100 milligrams deciliter. We have residual inflammatory risk. We have residual thrombotic risk and residual triglyceride risk and residual Lp(a) risk. So I think that we need to treat a complete picture, and with this, we do have new drugs that are coming, and we will benefit of reducing all the residual risk for our patient. So with this in mind, let us move to Alberto, and let us hear your talk. Alberto, please.
Thank you, Professor Zamorano. It's a great pleasure joining you today, and distinguished speakers and friends. And actually, I'd like to thank the Spanish Society of Cardiology for their very, very kind invitation. So the topic today is the residual risk. What is this? And Professor Zamorano, you already helped out in highlighting what might be, and particularly focusing on the role of lipids and inflammation and how to identify the patients. These are my financial disclosures, and this is one of the definition. Professor Zamorano already introduced the concept of residual risk. It's a risk of macrovascular events that we see very often in our clinics, from established risk factors such as dyslipidemia, hypertension, as well as emerging risk factors that we see in our patients in spite of treating them according to the most updated guidelines. Now, since we're focusing on lipids, we all understand that LDL cholesterol is and remains the primary target for lipid screening, for diagnosis and management of dyslipidemia. As Professor Zamorano said, on high-intensity statin treatment, because this is the background, we see very often recurrent events in our patients. And the residual risk recognizes multiple components. Some of them are lipids, not optimally controlled LDL cholesterol, hypertriglyceridemia, increased levels of Lp(a), but also inflammation and a prothrombotic state may help out accounting for the residual risk. Now, we'll be focusing briefly on LDL and then on inflammation and triglyceride. And I'll show you like triglyceride and inflammation, as well as a prothrombotic state, are kind of interconnected among each other. So over the past 3 decades, we've been able to more efficiently reduce LDL cholesterol, thanks in our patients to more potent pharmacological approaches, mainly statin inhibition. Now, combination therapy from the original 4S trials, where the treated patients were reaching 170 milligrams per deciliter to care, prove it, TNT down to 77 with atorvastatin 80, and then on the Improve It trial in 2015, combination therapy, simvastatin, ezetimibe, LDL cholesterol in treated patients 54, which is basically the goal for very high risk in the current guidelines. So in spite of the fact that we've been able to decrease or reduce cholesterol up to 80% as compared to baseline, we still face a remarkable residual risk, and it's clinically relevant. And so the risk of recurrent events needs to be further reduced. Now, the most recent trial, and Professor Zamorano already hinted at it, is Fourier. There is also Odyssey outcomes with PCSK9 inhibitors, where basically new goals and new levels, low levels of LDL cholesterol being reached, particularly about 30 milligrams of LDL cholesterol were the medium levels in the Fourier trial. So let me start from this trial, because this is a trial where the lowest LDL cholesterol in history of the trials have been reached. Now, Professor Zamorano showed the head-to-head Odyssey outcomes and the Fourier, and what is the residual risk of the overall population. Let me focus on a specific group of patients, for example, patients with diabetes. And this is the graph on the left-hand side of the slides. Those without diabetes in Fourier are on the right-hand side. These are patients with in secondary prevention with established cardiovascular risk and established cardiovascular disease. Now, if you can see, the first point that I like to make is that the two curves, whether it's placebo, and in Fourier placebo means high-intensity statin, or evolocumab, which is evolocumab and high-intensity statin, the events observed in patients with diabetes are higher than those without patients without diabetes. Now, interestingly enough, in patients with diabetes on evolocumab and high-intensity statin and an LDL cholesterol of 30 milligrams per deciliter, less than 1 millimoles, the event rate observed in the Fourier trial was higher as compared to those without diabetes, on placebo, which means only high-intensity statin, and an LDL cholesterol of 90 milligrams per deciliter. That tells you that remain, despite wiping out LDL cholesterol, we still have a significant number of events observed, particularly in this case in patients with diabetes. So let's rule out or exclude the possibility that we have an uncontrolled LDL, because we know that in Fourier was extremely well controlled. Let's focus on the contribution of inflammation, particularly high sensitivity CRP, remaining in the Fourier trial. This is a graph that shows different levels of LDL cholesterol according to increasing levels of high sensitivity CRP, from less than 1 milligram per liter to greater than 3. Now, as you can see, whatever is the level of LDL cholesterol, it decreases as we move from right to left. higher CRP are associated with a higher risk. But let me focus your attention on the lowest LDL cholesterol group. I mean, we're talking about patients with an LDL cholesterol less than 20 milligrams per deciliter, so which is 0.5, 0.6 millimoles. Now, the event rates observed, and this is cardiovascular death, non-fatal stroke, and MI, increased by almost 70% in those with high sensitivity CRP greater than 3, as compared to those on 20 milligrams of LDL cholesterol with a sensitivity with a CRP less than 1 milligram per liter. So there is a 3.6 absolute increase in event rate in patients with almost no LDL. Now, is this common in the trial with lipid-lowering agents? Well, let's take a look at what happens in Prove It and Improve It. Those are trials, particularly Improve It, where an effective and intensive lipid-lowering management was indeed applied. And as you can see here, if you look at those with an LDL nicely controlled, at that time the LDL cholesterol goals were less than 70 or 1.8 millimole, and the CRP persistently higher than 2 milligrams per deciliter, we're talking about 1/3 of the population in this trial. So it's a significant number of patients that remains at increased cardiovascular risk due to persistent inflammation despite an effective lipid-lowering management. Now, let me show you that there is also a second player that is quite relevant, and it's hypertriglyceridemia. Hypertriglyceridemia in connection with a nicely controlled LDL. When you look at lipoproteins, we are used to think about LDL as the only atherogenic lipoproteins. During the past 10 years, the evidence have come out very robustly that other lipoproteins are equally atherogenic per particles, and these lipoproteins are indeed the triglyceride-rich lipoproteins. So we have a whole range of atherogenic lipoproteins, not only the LDL. For too long, we've been thinking about the triglyceride and triglyceride-rich lipoprotein as not atherogenic, simple bystander, as Dr. Jekyll in his latest version of The Mummy, played by Russell Crowe. During the past 10 years, we realized that these innocent bystanders are not really innocent bystanders, but are highly atherogenic. Now, we knew it and simply forgot. Now, this is evidence from the past. 1994, Dick Abel and John Kane, California, they look at patients undergoing coronary artery bypass grafts. They look at the lipoproteins in the blood of these patients. This is a picture at the microscope. On the right-hand side, the LDL, on the left-hand side, larger particles, the triglyceride-rich lipoproteins, but they also look at the plaques, again, the lipoproteins inside plaques extracts. And what they found is that, of course, they found the LDL inside the plaques, but they also found that up to 36% of the lipoprotein cholesterol inside these coronary plaques were coming from triglyceride-rich lipoproteins. So we knew from the very beginning that the culprits were there. And it's nice to understand that triglyceride-rich lipoproteins are atherogenic in a slightly more sophisticated way as LDL, because they penetrate through the intima through the endothelium into the intima. So like the LDL are taken up by macrophages that get stuffed by these lipoproteins, and at the end they become foam cells and they make the plaque grow. But inside the bloodstream, the triglyceride-rich lipoproteins undergo lipolysis thanks to the lipoprotein lipase action. Lipolytic products are highly pro-inflammatory, leading to endothelial dysfunction, and they modulate the platelet aggregation. So that's the reason why I said inflammation, procoagulant state, and hypertriglyceridemia are somehow interconnected. Let me show you evidence that was published a few years ago, but very robust, from the Copenhagen General Population Study. Almost 50,000 participants. They look at the high sensitivity CRP, adjusting these results by a number of potential confounding factors. 40 milligrams increase in LDL cholesterol in this population was associated with, on average, a 6% increase of high sensitivity CRP. Now, the same increase in the triglyceride-rich lipoproteins cholesterol was associated with a 36% increase in high sensitivity CRP, suggesting for the same amount of increase in cholesterol, a more powerful pro-inflammatory role of triglyceride-rich lipoproteins. These are carotid plaques that were taken off in Padova, and actually when published this paper quite a long time ago, almost 10 years ago. We stained and looked at the core of the plaque section according to antibodies that were staining macrophages. This is the media, this is the atherosclerotic plaque. On the left-hand side are staining with antibodies that recognize macrophages. On the right-hand side is the atherosclerotic plaque. This is the media, and this is what's left of the lumen, are smooth muscle cells. And what we found is that the number of macrophages was not associated with cholesterol, LDL cholesterol level, but was positively and significantly associated with the concentration of triglyceride-rich lipoprotein, whereas the smooth muscle cells were inversely correlated the number of with the triglyceride-rich lipoprotein. So hypertriglyceridemia leads to plaque that is rich in macrophages, poor in smooth muscle cells. That's the unstable plaque. So no wonder that Peter Libby recently, when he looked at some non-traditional risk factors driving arterial inflammation, he mentioned triglyceride-rich lipoprotein as one of the components that might set the atheroma aflame. Just to give you an idea, this is called TG-REAL, is a retrospective cohort analysis, very large population, the relevance of hypertriglyceridemia, almost 160,000 normal triglyceride, hypertriglyceridemia, and very high triglyceride. You see the range in milligram per deciliter. They look at atherosclerotic cardiovascular events. The reference population were normal triglyceride, while mild to moderate elevation of hypertriglyceridemia was associated with doubling of the atherosclerotic risk when the model was adjusted by gender and age. In the multivariate adjusted model, 60% elevation as compared to normal triglyceride. And when they look at overall mortality, there was a 61 increase in those with high triglyceride between 150 and 500, and almost a 50% increase on the multivariate adjusted model. So moderate to severe elevation of triglyceride in these low to moderate risk population in Italy significantly increased both of all-cause mortality and atherosclerotic events. Now, this is another very interesting study published again by the Copenhagen colleagues, a general population study. 13,000 statin-treated patients. They look at above or below the median non-HDL cholesterol and LDL cholesterol. Of course, the reference population and the risk on top panel all-cause mortality, on the bottom panel myocardial infarction, was the population that had both non-HDL cholesterol and LDL cholesterol below the median. And at the bottom, you see what the median levels were. Now, what they saw is that the population at the higher risk in these statin-treated patients were those that had an LDL cholesterol remaining below the median, but the non-HDL cholesterol was above the median. 23% increase, significant on all-cause mortality, and 82% increase on fatal and non-fatal myocardial infarction. Now, if you look at graphically what it means to have a non-HDL cholesterol not at goal with an LDL cholesterol at goal, clearly highlights that the culprits are the triglyceride-rich lipoprotein. So this study once again shows that in a context of a nicely controlled LDL, hypertriglyceridemia associated with both increase on all-cause mortality and cardiovascular events. So just to summarize, raised triglyceride concentration are indeed an additional causal risk factor for cardiovascular disease and all-cause mortality. Hypertriglyceridemia is associated with inflammatory component of the atherosclerotic plaque, particularly components that are making the plaque phenotype towards the unstable plaque. Elevated triglyceride in this large Italian population, I showed you the TG-REAL study, is associated with a high risk of cardiovascular events and high risk of overall mortality. In a large cohort of statin-treated people in Denmark from the Copenhagen General Population Study, elevated triglycerides were indeed associated with higher all-cause mortality, 23% higher, and myocardial infarction, 82%. So across a number in France, there are similar data. So let me conclude, because my presentation was to hint at the phenotype of these patients with high cardiovascular residual risk. So the patient's phenotype clearly is on optimal LDL control, what we did so far. Patients remaining with a mild elevation of high sensitivity CRP, not very high, between 2 and 3, 2 and 4, and persistent or persistent G elevation. Now, do we have evidence, as Professor Zamorano hinted, that there are trials, randomized trials, that provide evidence that tackling these particular risk factors for residual cardiovascular risk pays off? Yes, there are. And as you see, the name of the trials underneath actually each of the components of residual risk are listed here. But we're looking at the common phenotype. I'm sure I'm oversimplifying it. A phenotype that may include a subclinical inflammation, persistent TG elevation, and maybe a prothrombotic state. Now, let me give you a hint of what that might be. Just a hint and one possible of the potential phenotypes. Now, in CANTOS, in COMPASS, in REDUCE IT, if you look at the BMI, was really on the verge of obesity. So remarkably overweight, almost on the obese range. And these are the 3 trials looking at 3 different components of residual risk. So, ladies and gentlemen, if I may suggest one of the potential phenotype that is associated with the multiple components of the residual risk is probably the visceral intra-abdominal obesity that is associated indeed with mild to moderate hypertriglyceridemia. It's associated with modest elevation of high sensitivity CRP and a state of subclinical inflammation. And it's also associated with pro-atherothrombotic phenotype. Thank you very much for your attention.
Thank you, Alberto. Indeed, it was a great lecture and extremely comprehensive. And let us move to John. You know, Professor Chapman is working in Paris, France, and now John is going to address the Icosapentethyl. What do we know? John?
Hola a todo el mundo. Hi, everyone. It's a great pleasure to join you on the occasion of this webinar supported by the Spanish Society of Cardiology. And I'd like to thank rather specially my friend and colleague, Professor Pepe Zamorano, for his very kind invitation to participate. The topic of my presentation today is actually the mechanism of action of Icosapentethyl. What do we know and what don't we know? So, Icosapentethyl is the precursor of a long-chain polyunsaturated fatty acid, which is icosapentanoic acid. This is a 20-carbon fatty acid with 5 double bonds. And the free icosapentanoic acid is liberated from its precursor icosapentethyl by lipases in the intestine upon consumption of icosapentethyl. EPA, as I'll refer to it, is then incorporated mainly into phospholipids, but some triglycerides, packaged into chylomicrons, secreted into the lymphatics, where the chylomicrons and that incorporated EPA travel to the liver, uptake in the liver in the form of chylomicron remnants. So essentially, there's a direct pathway from the intestine to the liver for phospholipids and triglycerides loaded with EPA. Very importantly, the advantage of this precursor icosapentethyl is it's highly purified, it's stable, it doesn't contain any oxidation products, which frequently occurs in preparations of omega-3 fatty acids. It has a long shelf life for storage. So a number of advantages in that respect. Now, what are the potential mechanisms which are implicated in the cardiovascular benefit, which are conferred by EPA, supplied or consumed, as we already discussed, in the form of icosapentethyl? Well, a number of major mechanisms have been documented. The first is reduction of triglycerides and triglyceride-rich lipoproteins. The second are the membrane stabilizing effects, which are specific to EPA, and these include inhibition of lipid oxidation and reduction of cholesterol domain formation in cell membranes. That's particularly important because that reduces the potential for the formation of cholesterol crystals. We'll come back to cholesterol crystals later in the discussion. Thirdly, there's a whole series of anti-inflammatory metabolites that are formed from EPA in plaque tissue and at other tissue sites. And the importance of these metabolites is that they are mediators that favor the resolution of inflammation. And we'll come back again to them. EPA exerts vasodilatory actions, primarily through upregulation of the production of nitric oxide. And finally, in a number of studies, EPA and other omega-3 fatty acids have been associated with mild antithrombotic effects, which are exerted primarily through action on platelet membranes and reduction of platelet aggregation. Now, let's first of all look at this question of triglyceride reduction by EPA in the Reduce It trial. Very importantly, there was no difference in the cardiovascular benefit as a function of the baseline triglyceride levels in the hypertriglyceridemic patients who were actually recruited into Reduce It. So we don't seem to be able to use triglyceride level as a marker for benefit in this trial, or even when Icosapentethyl is administered. But if we look a little bit further, and I'll ask you to look at this second panel here, if we look at a subclass of triglyceride-rich lipoproteins, and these are the remnant lipoproteins, we measure the cholesterol in those particles, what we see in both the marine and anchor trials is that there's a highly significant reduction in remnant lipoprotein cholesterol, which is greater than the reduction in triglyceride. These, of course, are primarily cholesterol-rich particles. They can contain some triglyceride. And so there's a very significant increase in the reduction of remnants relative to the placebo. This is on the background of statin in both arms in each of these trials. Now, it's particularly important to discuss the fact that within the last 5 years, genetic data have identified triglyceride-rich particles, and particularly remnants, as being causal in the pathophysiology of atherosclerotic cardiovascular disease. Now, this includes myocardial infarction, ischemic stroke, and aortic valve stenosis, and it even includes cardiovascular mortality, and we've seen that in a publication this week, in fact yesterday, on the Reduce It trial. And these findings are based on Mendelian randomization analyses, focusing on a number of proteins and enzymes which are critical to the metabolism of remnants. And here we see remnant formation and metabolism. It's taken from our recent EES consensus paper in the European Heart Journal. So both chylomicrons and hepatic VLDL are subjected to remodeling at the endothelial surface by enzymes and lipid transfer factors, which leads to the formation of remnants, which are then taken up mainly through the LDL receptor in the liver. So that then gives us an overall metabolic pathway, if you will, for the production of remnant particles and their significance in atherosclerotic cardiovascular disease. Now, what is the nature of the cardiovascular benefit in Reduce It? Well, very recently we've seen that, in fact, the benefit goes far beyond the reduction, here you see in green, in first cardiovascular events. It extends to the second, to the third, and even the fourth event, and actually the benefit increases. In the fourth event, it's even over 40% reduction in the relative risk. So what's happening here is that the individuals who are at the greatest risk for additional events are benefiting even more from intervention with high-dose Icosapentethyl in the Reduce It trial. So the question is, what actually is happening here? Well, what we need to do is look at the plaque. We need to look at coronary plaques, particularly. We see here a rupture-prone plaque. It's the thin fibrous cap has ruptured under mechanical stress. You can see loads of fine filamentous structures. These are cholesterol crystals in the necrotic core. Here you see these cholesterol clefts due to crystals, and you see the thrombus that's formed once that fibrous cap has ruptured, contact of blood and with prothrombotic components in the plaque and occlusion of the vessel with a thrombus. Now, what are the key characteristics of these rupture-prone plaques? Well, a thin, inflamed fibrous cap, abundant foam cells from macrophage and smooth muscle cells, a soft, lipid-enriched necrotic core mainly cholesterol crystals, other oxidized lipids, and the presence of a number of extracellular lipid pools outside then any cellular structures in the plaque. There are also a number of other components that favor plaque rupture, and I just mentioned to you spotty microcalcification that creates cleavage planes in the plaque. Now, let's look at one of the 4 major imaging trials that have looked at plaque structure over the period of an intervention with icosapent. And what you see here is the Evaporate trial of Budoff and colleagues. They treated the intervention group with icosapent for 18 months. The placebo group, again, both were on a statin background, and of course the mineral oil placebo was involved here. But very importantly, what this group did was to use multiple detection CTA to look at low attenuation plaque volume. This is essentially looking at the lipid volume in the plaque. And what you see here is with that methodology, there was a 100% increase in the placebo group and almost a 20% reduction, highly significant, of this low attenuation lipid content in coronary plaque over the period of 18 months with this intervention. Now, I should mention to you that the Cherry trial, which I'm not going to show you, in Japan, had no placebo, so there was no mineral oil involved. This was the patients acted as their own controls. There was a statin background. Very similar results were seen, so we can't simply say, oh, this is the placebo that's accounting for this major effect. That doesn't appear to be the case, and in fact, we believe that the placebo benefit, the benefit of the mineral oil, is as low as 3% or less in the overall clinical benefits seen in the Reduce It trial. Now let's go a little further. One of the major features of icosapentanoic acid is it seems to be preferentially taken up by the atherosclerotic plaque. It decreases plaque inflammation and it increases plaque stability. This was first documented by colleagues in the UK in 2010. Now, why is this the case? How can this happen? Well, basically, when EPA is incorporated into the bilayer plasma membrane, it stabilizes the normal membrane structure and it prevents the formation of what we call cholesterol crystalline domains. In other words, the precursors of cholesterol crystals. So a very important role in stabilizing membrane structure, inhibiting lipid oxidation, and also there is a preservation of normal membrane function by EPA. Now, another dimension of EPA is the production of anti-inflammatory mediators, which are metabolites of EPA. So COX and LOX enzymes, which are distributed in many tissues, but particularly in plaque tissue, create these resolving compounds and also prostacyclin, which are major anti-inflammatory mediators. And these are preferentially produced. They displace arachidonic acid from the active site of these enzymes. So there is a change in the equilibrium. EPA dominates when icosapent is administered at doses of up to 4 grams a day, and the pro-inflammatory metabolite production from arachidonic acid is significantly diminished. So this appears to be a major pathway whereby EPA contributes to reduce inflammation in the plaque itself. Now let's summarize this data. What we have here, I'd like you to look at the right-hand side of this slide, and these are the effects that have been documented of EPA on the atherosclerotic plaque in the coronary circulation. And what we see is, first of all, reduction in plaque volume, so regression. That's been documented in 4 imaging trials with icosapent, an increase in lumen diameter, a decrease in plaque thrombogenicity, a decrease in arterial thickness, but very importantly, a significant increase in fibrous cap thickness, which of course favors stability of the plaque and reduces its vulnerability to mechanical stress, for example, in systole at high at high cardiac rates, at high pulse rates. There will be a gain, if you will, in protection of the plaque by a thicker fibrous cap, and that is intimately related to reduction in inflammation, reduction of metalloproteases, in particular by macrophages, by smooth muscle cells in the plaque under the influence of these anti-inflammatory metabolites of EPA. So to conclude, first of all, we cannot attribute all of the benefits, all of the cardiovascular benefits in Reduce It to triglyceride levels alone. Clearly, there is a contribution of reduction of remnant particles. There are other effects which we believe to be important and for which evidence is now emerging. These are anti-inflammatory and antioxidant effects, diminution of plaque inflammation, then reduction in plaque lipid content, enhanced fibrous cap thickness and stability, and antiplatelet effects. So these translate into plaque regression, modification of plaque composition, which favors stability of the plaque, and of course these benefits go well beyond any benefits of triglyceride lowering. And I think the final point here to stress is that there's a very strong correlation between on-treatment plasma levels of icosapentenoic acid and reduction in cardiovascular events. This was demonstrated in a sub-analysis of Reduce It, and that correlation appears to be one of the key factors which underlie the considerable cardiovascular risk reduction seen in these very high risk patients in the Reduce It trial. So I thank you for joining me on the occasion of this webinar, and I look forward to your questions. Thank you very much.
Thank you, John. Indeed, it was a terrific lecture. And then let us move to the third lecture, but let me remind all of you that the important ones are you, the attendees, and you can share your thoughts on Twitter and follow in the hashtag residual risk or hashtag CBBT 2022. So we are already receiving some questions, and then we move to Xavier Garcia-Moll from Zambon in Barcelona. So Xavier, Icosapentethyl, evidence and guideline recommendation.
Thank you very much, Pepe, and thank you very much to the Spanish Society of Cardiology and for Amarin for the sponsorship and this wonderful company. So let's move on. Residual risk, cardiovascular risk factor. What is the role of icosapentethyl? So, the main indication in Europe and in Spain, basically in Spanish, is that this molecule is being indicated to reduce cardiovascular, the risk of cardiovascular events in adult patients already treated with statins, with a high cardiovascular risk and with high triglycerides, having had cardiovascular disease or with diabetes and at least another cardiovascular risk factor. Now, the major randomized studies with EPA, as mentioned by John, basically the main clinical one is the Reduce It, and the Evaporate helps us to understand, as mentioned before, how it might work within the plaque. So what about Reduce It? Reduce It was a randomized trial, multicentric, double-blind control, statin with IPE 2 grams every 12 hours versus statins plus placebo. There were more than 8,000 patients included with established cardiovascular disease, about 71% of all patients included, or with type 2 diabetes and another cardiovascular risk factor that summed up about 30%, altogether already treated with statins and with high serum triglycerides, defined as being higher than 135 and lower than 499 milligrams deciliter. Mean follow-up was about 5 years, 4.9 years. And the primary composite endpoint was a composite of cardiovascular death, non-fatal MI, non-fatal stroke, coronary revascularization, or unstable angina. And the key secondary endpoint was composed of the major components of the primary composite, which is composed CV cardiovascular death, non-fatal MI, and non-fatal stroke. Now, the main results, as shown before, we can see it in the primary composite endpoint. We have a reduction, an overall reduction of almost a 5% with an NNT to treat the whole of the patients of only 21. And in the key secondary endpoint, we do have another significant reduction with an NNT of 28, which is really very significant results. And they are very appealing to deal with those patients. Now, if we go by the pre-specified subgroups, we can see that we are almost always within the good side of the picture, sometimes within crossing the line. But basically, the one that is in the right side of the picture, with no statistical significance, is the primary preventive cohort, because there was a rather low event rate, about half of the secondary prevention rate, and therefore the confidence interval is wider than it is in the secondary prevention, and therefore crossing the unit. But above all, most of the primary, the pre-specified subgroups are statistically significant. Renal function, diabetes at baseline from the United States or otherwise, less or higher than 65 years of age, white or other, male, female, etc. So, and baseline, as mentioned before by John, baseline triglycerides, they're both being high or low. They were significantly protected by IPE. And with baseline cholesterol and low HDL cholesterol as well, meaning that non-HDL cholesterol was high and therefore also benefiting from the molecule. And with baseline statin, basically those at high or moderate statin regime, they were benefited, but there were very low number of patients with low baseline statin intensity, and therefore those ones, the ones that are, well, maybe it's a sort of a random result. And as baseline LDL cholesterols and also CRP being low or below 2 or above 2, all the groups are benefiting from the IPE molecule. Now, regarding primary composite endpoint, as mentioned before, there is a highly statistical benefit from the molecule and the key secondary composite as well. And then if we are looking at several components of those endpoints, we can see that cardiovascular death or non-fatal myocardial infarction are also reduced, significantly reduced. Fatal, non-fatal myocardial infarction are reduced. Urgent or emergent revascularization reduced. Cardiovascular death, hospitalization for unstable angina, fatal or non-fatal stroke, or death from any cause, non-fatal myocardial infarction or non-fatal stroke. So all major cardiovascular endpoints are reduced, significantly reduced. Now, what about safety? The treatment emergent adverse events were non-significantly, they were mostly the same between Icosapentethyl and placebo. And regarding more significant, as mentioned before, it favors thrombolysis, or there may be an increase of bleeding events. There was a trend to have more bleeding events in the active treatment, but there was no trends to having higher gastrointestinal bleeding, nor central nervous system bleeding. So it is safe from this point of view. And there were another side effects such as diarrhea that were, as if to say, protected by the molecule, because there was more constipation, there was more peripheral edema, and slightly more as well atrial fibrillation. So, as mentioned before, in this study there was a large plan of pre-specified different analyses. One of them was the analysis of total episodes throughout the study. So, as mentioned by John, there was a reduction from the first events, but also from second, third, and more than fourth, and so on events. So throughout the study, there was a benefit. And those that presented an event, they were further protected for reducing the probabilities to having another event. So what about prior myocardial infarction? There was, again, a significant reduction in first myocardial infarction, another second, as if to say a second myocardial infarction, and further events as well. So in total, first events and all events, both from primary composite endpoints and from key secondary composite endpoint. And the same was found for cardiovascular death, sudden cardiac death, and cardiac arrest, which are very relevant results. And what about prior surgical revascularization? Again, the same results, significant results, reducing first events, but also second and third or further events. And depending on renal function, usually renal patients are the ones that are usually dismissed or disregarded in these studies. But in here, if we look at the ones that were with glomerular filtration rate below 60, there was a significant reduction. And in those between 60 to 90, again, another significant reduction. And those above 90, significant reduction. As mentioned before, the patients with worst renal function were the ones that had the higher risk. But again, despite the baseline risk by renal function, all of the patients had a very straightforward statistical relevant benefit and clinical benefit as well. So reduction of revascularizations, all revascularizations, urgent, elective, first, second, third, and both percutaneous and surgical revascularization were reduced. And this is actually the first reduction in revascularization from a non-anti-LDL molecule, which is relevant to tackle with residual risk. And when dealing with primary prevention patients that were about 30% of the global population, and secondary prevention, which are 30%, we see that there is a statistically significant reduction in secondary prevention with an NNT very low, only 14. And in primary prevention, there were a shorter number, and the event rate in the control arm was about half of the secondary prevention, and therefore we have a almost significant trend. I mean, a trend almost significant to have a significant result in reducing the primary endpoint. But then in secondary prevention, we are dealing with NNTs of only 14. So the EVAPORATE trial has been dealt before by John. I won't insist on this. It's just to show this slide that we do have the primary endpoint low attenuation plaque that is reduced, whereas in the placebo arm was increased. But we also have a reduction in fibrofatty plaques, in fibrous plaques, and with no change in calcification, whereas we do have an increase in calcification in the placebo arm. So all in all, we do have a total non-calcified reduction of plaques with a total plaque burden reduction, which is highly significant. And this is why the EMA has accepted EPA as a new active substance to tackle with this cardiovascular risk, with the indication to reduce the risk of cardiovascular events in the adult statin-treated patients at high cardiovascular risk with elevated triglycerides, which is more than 149 milligrams deciliters, and established cardiovascular disease or diabetes and at least one of cardiovascular risk factor, which is population studied in the REDUCE trial. So regarding the mineral oil issue that I mentioned as well, John, before, all FDA, the Health Canada, and EMA has assessed the eventual relevance of mineral oil used in the placebo group, and all the organizations have found that if anything, the worst scenarios, assuming that there was a slight effect, which is about 3% that has been calculated, the efficacy on MACE of the molecule has to be attributed to the molecule, not to the use of sort of deleterious placebo in the control group. So all the FDA, Health Canada, and EMA are aligned to this. And this is why probably in most of the publications that have been issued after the publication of REDUCE do include Icosapentethyl in the drug with outcome trials with significant results. And it has to be mentioned that both volanesorsen and vupanosen have been approved for pancreatitis, but not specifically to lower triglycerides. And pemafibrate in the pivotal trial have not have statistically relevant results. So this is why also when dealing with plaque regression strategies, icosapent acid or EPA are dealt and are taken into account to dampen the inflammatory response. So if we follow the 2021 guidelines regarding prevention in clinical practice, we are dealing with those patients that have been defined to be included in Reduce It, and the patients that have been accepted for the indication to the use of the molecule are all in the very high risk. And if we have a very stable patient with past atherosclerotic disease, we can calculate the cardiovascular risk with the Eurospide risk calculator or the SmartRich calculator, and if diabetic with the DIAL model. But anyway, most of our patients will be already, we know that they are in the very high risk, and therefore the goals that we have to have are most aggressive. In Western countries, I think that we all agree that the first step can be skipped, and we go straight to the second one, which are the more aggressive treatments to give, to achieve a goal of LDL below 55 milligrams deciliter, which is less than 1.4 millimoles liter, with blood pressures and the double antiaggregation and so on. But if we are doing this, we have to take into account the residual risk, as mentioned before by both Alberto and John, and therefore we have new molecules to tackle with this residual risk. And this is why in the guidelines for the management of dyslipidemias, Icosapentethyl was included with a 2A/B recommendation, and in the prevention guidelines has also been mentioned with a 2B recommendation. And in the American guidelines, we do have a specific figure for the management of hypertriglyceridemia and the role of IPE. Is not a straightforward figure, but the molecule is taken into account for the management of hypertriglyceridemia as well. And all these with a very good safety profile, with a slight increase in atrial fibrillation and maybe a slight increase as well in bleeding, but not insignificant and significantly prognostically significant bleedings. So from my conclusion would be, from a clinical perspective, Reduce It trial has reduced significantly the endpoint by 25% with an NNT for the whole study of 21. Reduce It trial reduces secondary key endpoint by 28%, which was cardiovascular death, non-fatal myocardial infarction and non-fatal stroke with an NNT of 28. When compared with placebo, IPE reduced 20% cardiovascular death, 31% myocardial infarction, and 28% stroke. The NNT in secondary prevention is as low as 14. And coronary artery studies have shown that it modifies plaque composition. And as mentioned by John, there are several other mechanisms that can explain the benefit regardless of the triglyceride baseline. And in addition to the lowering serum triglycerides, there is a clinical benefit, not only reduce triglycerides. So what do guidelines recommend having in mind those results? At first, it is recommended to assess residual risk in those high cardiovascular risk patients. It is important to measure non-HDL cholesterol and triglycerides in patients with high cardiovascular risk by the reasons mentioned before. And in those high-risk cardiovascular patients with an LDL cholesterol levels within range, but with high triglyceride levels, treatment of those triglyceride levels and treatment of those triglyceride levels with IPE have received 2A or 2B recommendations in the ESC guidelines. And this is all. Thank you for your attention, and ready for our questions, if any questions.
Yeah. Thank you, Xavi. I think it was again a great lecture, and it's incredible to have you all as great teachers. We have many, many questions. Let us try to be short, and we can accommodate as many as possible, because even my WhatsApp is booming with questions. Yeah, so let me start with you, Xavi. We do have a reduced trial that you've shown us is with great results. For you, we have one question here. Why reduce is so important? And if you think that we should change the guidelines.
Well, this is one study, therefore the B of the recommendations, but it's a very relevant study because it tackles with a different issue. From different mechanisms, it adds benefit to what we do have now, which are the LDL lowering drugs, and with different mechanisms. Usually in cardiology, when we are told that such drug has several benefits from several pathways, we always question, yes, but what about the clinical relevance? What about myocardial function? What about stroke? And what about death, cardiovascular death? And those endpoints, hard endpoints, they were all achieved with clinical and statistical significance in this study. And therefore, it is important. And probably guidelines should have to be to include IPE in the armamentarium.
Pepe, if I may add a comment, and I think I'm sure John can add a comment as well. I don't remember in the past 15 years any trial with any lipid lowering agents giving such robust results. Even if you consider the placebo mineral oil problem that John pointed out accounts for at the most 3% of the benefit seen with the IPE. So it's really a quite relevant study if you consider also that has no impact this approach on LDL, which is the mainstay for cardiovascular prevention. So it indeed provides a strong evidence. I don't know what John thinks, but
could I perhaps just add to your comment, Alberto and Javier? I think that what we have here, and it just sort of occurred to me really, is we sort of have a bridge between the CANTOS trial, where clearly reduction of inflammation directly by addressing IL-1 beta was highly successful, but had some adverse effects, which was significant. And here we see in the Induce trial, another dimension, another approach to reduction of inflammation, if you will, bringing us the very significant clinical benefit that Javier described. So it's a very interesting. Mechanisms are coming together after many years using different agents.
Yeah, this is clear. Well, John, let me stay with you because here is a difficult question for a good friend. Why Icosapentethyl is different to other products with a combination of IPA with DHA without cardiovascular outcomes? Why this is different?
Well, actually, there are several points to be brought up. The first one is that docosahexaenoic acid is 2 carbon atoms longer and 1 double bond in addition to that in icosapentenoic acid. And Preston Mason and others have done some very detailed physicochemical studies showing that there is much less preservation of bilayer membrane integrity with DHA as compared to EPA. So that would be the first point. So on a molecular basis, there's quite solid evidence that those two fatty acids, polyunsaturated fatty acids, do differ. The second point is that across the different trials, the relative concentrations of DHA and EPA have ranged considerably. And I think that what has appeared just very recently in a meta-analysis, and one of the leading authors was Michael Miller in Philadelphia, the suggestion has appeared that it may be that when we use mixed preparations of DHA and EPA, there may be a degree of neutralization of the potential clinical benefit and mechanisms of action of EPA by DHA. So I think it's very important that the Reduce It trial was EPA only, and it's given us a very clear picture, I think, in, as Javier described, two very high-risk populations that constituted the patient cohort in the trial. So I would point out that in this very recent meta-analysis, covering all of the trials with omega-3 fatty acids, various mixtures of DHA and EPA, there is a small signal for an overall clinical benefit. And I think that that probably depends on the relative ratio, relative concentration of EPA and DHA in that omega-3 fatty acid preparation. That's one point. And I think the other point that's been very seriously neglected is that many, many patients consume omega-3 fatty acid preparations which are insufficiently controlled for toxic oxidation products. These fatty acids are exceedingly sensitive to oxidation, and I think that we've neglected this over the years, and we really need to come back to it in a very strict, how can I say, chemical, obviously, or biochemical, but equally clinical context, because it may be that if we simply say, well, look, there's the potential for benefit from a mixed omega-3 preparation in which EPA predominates, we need some very strict quality control, I think, on these products.
Yeah.
And if I may? Sorry.
Sure.
If I may,
sure.
As mentioned by John before as well, the concentration that was achieved in blood in the Reduce trial was much higher than the one in other studies. And therefore, as mentioned, concentration and anti-inflammatory effects do have an association, and therefore this would be another mechanism to explain the benefits in Reduce It. And in the other study, which is the strength study, let's name it, the placebo group used the corn oil, and corn oil may have a slight benefit as well. So therefore, lessening the statistical power in strength. So, well, but anyway.
Very good point, Xavier. Yes, absolutely agree. Yeah.
And last but not least, the dosage.
That's right.
We have so many meta-analyses that basically ended up with no effect of omega-3 fatty acid. And the large majority of the trials of those meta-analyses were looking at 1 gram, 0.8 grams of omega-3 fatty acid. So let's keep in mind that the effect on lipids, on inflammation, on aggregations, is seen only at certain dosage, and that dosage starts at 3 grams a day, if not 4, as in the Reduce It. So let's not make confusion with 1 gram a day. That was the old GC trial that, of course, in the recent trials failed to provide cardiovascular benefits. This is completely different dosage. It's a pharmacological. It's not a food supplement. It's a pharmacological approach.
Okay, so then let us, because we have questions about that strength study that failed. So Xavier said that it may be related to the placebo group. Alberto, John, what is your main explanation why strength failed?
Well, my explanation is that in biochemical terms, there seems to be a neutralization of the benefits, of the beneficial actions of EPA by DHA. And I think the best explanation at a molecular level that we have for that is the difference in the way that EPA preserves membrane structure and function as compared to DHA. Now, I would actually go a little bit further. There is emerging evidence that cholesterol crystals are a critical component in destabilizing plaque. And just recently, looking at some of these imaging trials, particularly with with OCT, there appears to be, in one of the Japanese studies, a significant 20% reduction in the number of plaque cholesterol crystals in individuals in the EPA arm. Now, this was not compared to DHA, I should add. So the evidence is mounting that we're clearly having distinct beneficial effects on plaque structure that directly relate to stability. We simply don't have that data for DHA. Now, some of us would very much like to see a trial designed where we have an EPA-only group, a DHA-only group, and a DHA-EPA. Possibly, obviously, we have to think about the placebos too. But we don't have that kind of data, and we need to think, as I think the comment that Alberto made, to think very carefully about the actual doses that we use of these two polyunsaturated fatty acids. But I would say the emerging evidence suggests that there's this kind of a neutralization, if you will, by DHA of EPA that probably occurred in the strength trial. And that probably is the best explanation at this time.
Yeah, I strongly agree with John. I think the difference is at the molecular level, the membrane level. You know, antioxidants, strong effect of EPA, which lacks on DHA, and not on triglyceride, because if you look at, you know, the triglyceride levels dropped in strength as well, not in other parameters, although ApoB did not change in strength, actually, which is another issue. I think the other point on top of differences at the molecular membrane levels of the two omega-3 fatty acids, I think needs to be seen on the trial. You know, look at the dropout rate in strength. Actually, we're talking about a very large dropout in both the placebo and the active group. So I think there are problems in the trial, and then the differences in the compound used at the molecular level, as John explained, that may account for the apparently conflicting results, in fact, that are generating a bit of a confusion among doctors. I must admit it.
Yeah, and Alberto, there's a question very, very interesting for you. What is the role of elevated triglycerides? Is a causal risk factor for atherosclerosis, or is a marker of high cardiovascular risk phenotype?
Well, I think that's a quite a key question. From the evidence that, as John and Xavier said, from the past like 15 years, we clearly understand that triglyceride-rich lipoprotein are atherogenic. We have Mendelian randomization analysis that tells that one triglyceride-rich lipoprotein, if we measure ApoB, is as atherogenic as one LDL. Now, the other point is that, as I showed you in my last slide, hypertriglyceridemia, moderate hypertriglyceridemia, is associated quite often with insulin resistance, diabetes, is the phenotype that also accounts for the presence of the other components of residual risk: pro-atherothrombotic state, mild increase in high sensitivity CRP, so a subclinical inflammation. So my answer is that triglyceride-rich lipoprotein are indeed causal in the atherosclerotic process, but they are also at the same time a marker for a phenotype, clinical phenotype, that is characterized by a very high residual cardiovascular risk, subclinical inflammation, pro-aggregant state. So I think we can use hypertriglyceridemia in both ways. Now, the key point is that you may ask, why lowering triglyceride in prominent did not result in benefit? That's the other key question, because if we believe triglycerides are causal, well, I was surprised actually. In the original fibrates trial, I think we missed to select the proper population. Most of the trials had a population with normal triglycerides, but the prominent indeed selected the population with triglyceride level comparable to the reduced. I think it was 220, 230 milligrams per deciliter. Once again, I think the explanation comes from the Mendelian randomization data. I told you one triglyceride-rich lipoprotein is as atherogenic as one LDL. But if you look what accounts for 10 milligram decrease in ApoB, which is number of particles for LDL, that's 14 milligrams of cholesterol, LDL cholesterol. The same effect is seen for 10 milligrams decrease in ApoB, in triglyceride-rich lipoprotein. You know how much are those triglycerides? 70 milligrams. So it looks like to have the same benefits of 14 milligrams decrease in LDL cholesterol lifetime, you need to have a 70 milligram triglyceride decrease, which means that probably to have a trial with significant results based purely on triglyceride reduction, we have to reduce triglyceride by a much larger amount as compared to the drug we currently have, fibrates particularly, actually. And that's the reason why also the IPE got other effects on board, like, you know, anti-inflammatory and pro-aggregant. I think the amount of lipoprotein, the triglyceride-rich lipoprotein range we should decrease, it's much larger to have a significant contribution to the residual risk than what we are able to do right now.
Exactly.
And in those patients with high cardiovascular risk, if the profile, as you mentioned, there is a low HDL with high triglycerides,
Absolutely.
and therefore meaning that whatever the LDL levels, the particles will be smaller, and therefore more atherogenic as well. So this is again another side
it's a complex combined mechanism, actually.
That's right.
Exactly. And John, here is a couple of questions for you. Is there evidence that EPA reduce plaque content of cholesterol crystals? And a second one, what is the mechanism, if it is known, of the antithrombotic effect of EPA?
Okay, so there is a study from Japan using OCT, published, I think, about 3-4 years ago, which very nicely shows a reduction, it's of the order of 20% in cholesterol crystal numbers in coronary plaque. And it was significant. The p-value was quite strong. So looking at the literature, that's the only study with OCT using EPA alone that has actually looked at that question. So it's preliminary, but it is entirely consistent with the physical chemistry, if you will, of EPA and its action in membranes in conserving, or in preventing, if you will, what we call cholesterol crystal domains in membranes. When in hypercholesterolemia, free cholesterol enriches plasma membranes of many cells. And those membranes, because of the increased cholesterol content, create these domains. And from those domains, we nucleate. There's a nucleation process, which is energy dependent and so on and so forth, from which cholesterol crystals are formed. And it's clear from in vitro and ex vivo data now, and the imaging data, that EPA does appear to have a distinct effect on preserving membrane structure and ultimately blocking this chain that would lead to crystal formation. So that would be the first response, I think. And sorry, the second question, Pepe, was?
Yeah, it was related to vasodilation. And so how does EPA induce vasodilation?
Well, basically, the story there is that endothelial nitric oxide synthase is an enzyme, particularly in the endothelial cell plasma membrane, that's especially sensitive to membrane bilayer structure. And Preston Mason in particular, and there's a number of reports in the literature that show that as you get cholesterol enrichment of that membrane, specifically in endothelial cells, you start to lose the efficiency of eNOS to produce nitric oxide. And we come back again to this membrane preservation, the structural membrane preservation by EPA, which maintains and even upregulates or favors production of nitric oxide and a vasodilatory effect. So, and there are several publications that document this in different models, in ex vivo studies. So I think that we're in a situation here where we're gradually seeing a coming together, if you will, of several mechanisms directly related to the structure of EPA, which ultimately translate to clinical benefit, to that Alberto and Xavier described. And it makes it tremendously fascinating because it's some of these aspects come back to statin benefits. I mean, when regression and changing plaque structure was looked at with statins, not in as much detail as has been done in Evaporate or Cherry, because we simply didn't dispose of these much more advanced imaging technologies 10, 15, 20 years ago. So I think these are data that reflect the tremendous technological progress in our field.
Yeah, we have here a last question from Nate Yao. I first heard about the drug during ACC 2022, but when will be available in Spain, Italy, or France? I know Spain at the end of the year. Italy, Alberto, do you know?
It's under consideration by the National Regulatory Agency, so hopefully it will be approved. Of course, with probably for certain type of patients, I believe on the background of an optimal LDL control, at least less than 100. My hope is that by the end of the year, early next year, we will have the EPA available.
And in France, do you know, John?
Well, you know, these sorts of approvals don't really advance terribly well in France. You can have a new agent approved, but unfortunately, there can be a very prolonged delay after that, so that an actual price, unit price, is fixed. And sometimes these delays can be as long as a year or 2 years. So at the moment, we have no really clear indication of when IPE will become available in France. But I think given the very considerable proportion of hypertriglyceridemic patients in France, that we are very hopeful that in 2023 this will be approved here.
Perfect. So I think it has been a great virtual meeting. Thank you all. Thank to the great teachers that we have. Thank to the Spanish Society of Cardiology and to Amarin for sponsoring this. I think that we have learned a lot. But remember what Napoleon said after Waterloo. So the best strategy failed in the battle camp. The battle camp is in your hands. So now we need to implement the knowledge. And we need to really know that even with the best LDL lowering strategy, we do have residual risk and we need to do better for our patients. Thank you very much. And I hope you have enjoyed the webinar. Thank you.